there. I'm Dr. Thomas Martin from the University of California in San Francisco, and we're here today with Blood Cancers Today, discussing bispecifics and how we incorporate these new novel therapeutics in our treatment armamentarium for relapsed multiple myeloma. And I'm joined with several esteemed colleagues.
Hi, I'm Angela Dispenzieri, Mayo Clinic, Rochester, Minnesota.
Hi, Ajay Chari, recently at University of California, San Francisco as well.
Ajay Nooka from Emory University.
Okay, let's talk a little bit about ICANS, because I've previously thought that ICANS really doesn't happen with bispecifics, but I've changed my tune a little bit. What do you think? Have you seen much ICANS, Angela?
With the bispecifics, not so much, but I'm not doing the inpatient service, so I just have patients that are coming back to me, so I'm not the best to answer that question, actually. But it doesn't seem to be, it's kind of as I read it. But.
Yeah, it doesn't seem to be as big of a deal, right? It's certainly.
Yeah.
How about in your experience, Ajay?
Well, I think part of it is a learning curve too and recognition. So I think early in the phase 1 dose escalations, we didn't see it much because we weren't looking for it. And then when you add in the mini mentals and you're waking up people at 3 a.m. and having them do these crazy assessments,
right.
We're picking up a little bit of changes. And some of that is in the setting of fever. So to your earlier point, is it febrile delirium or is it ICANS? I mean, and does it matter? Like if they're going to be, they're all getting dex and it usually resolves. So I think in general, bispecifics probably don't have an ICANS rate more than 10%. And it's typically low grade and I think self-limited, so it's not as concerning, I think, as the CAR-Ts.
And what do you guys think in terms of so for CRS with bispecifics, do you worry about it after cycle 1 or cycle 2? Do you worry about CRS at all? They're outpatient. Are you seeing any CRS, any late CRS, anything that you worry about?
I'll make a couple of points. One is we did this natural experiment during COVID, right? So New York being the epicenter, we had a lot of patients on bispecifics that we had to hold because there was no vaccine. And a lot of these patients were in remission. So our policy was, if you're in remission, we're skipping drug. If you're actively progressing or active disease, we continue. So when you do the hold, the vast majority of patients did not have CRS with retitration upward. So the protocol mandated that you have to step up. But I think currently the protocols say if you hold, REMS program says 28 days. Some of the protocols allow 35 days before you re-step up. But I would just say, like, if you're taking a break in a patient for AE, toxicity, whatever, if they have bulky disease, I probably would be a little cautious and watch closely because they could have it again when you activate those T cells. Yeah. I think we also need to be mindful of infections for another cause of fever. Also, I have had a couple of patients with HLH, which just bulky disease patients on bispecifics. So I would say that's another subgroup that you need to be aware of. And then lastly, when we've seen some combination strategies, when you particularly add certain drugs, you get these weird fevers, not just during step up. And I think that's when I've seen it. But just monotherapy, I usually have not seen CRS by itself.
Well, you brought it up, infections, because that's the other big thing, right? So when we see the long-term data, upwards of 70 to 80% of patients are having some infections during their therapy for bispecific. A lot of that is in the first few months when they're neutropenic, et cetera, but it also continues over time. So, Ajay, what are you doing for prophylaxis for patients for infections for bispecifics?
So we have a standing order as discussed by the entire myeloma group. So everybody that gets a BCMA targeted therapy will get IVIG on a monthly basis, irrespective of the IgG levels, irrespective of whether the patient has an infection or not. We also use the PJP prophylaxis. We also use the antiviral prophylaxis. We don't use antibacterial prophylaxis until the time there's a trigger for initiating an antibacterial prophylaxis.
Like febrile neutropenia.
Like a febrile neutropenia. And we have routinely monitored our viral panels. Like we are the same group as the transplant group. So allotransplants, we routinely use the CMV monitoring, adeno monitoring, EBV monitoring. We have used the same kind of a platform for the bispecifics on a weekly basis to evaluate whether these patients are at a higher risk for viral activations. If not, we always can go back and change our process. So it is all building upon what you're learning from your patient population for the betterment of the care that you give.
And for viral reactivations, any pearls about viral activations? Anything? Are you seeing any CMV disease or any other viral specific driven disorders?
So in our first 50 patients, we have not seen any. So which brought the discussion back to, so should we do all these? But the real experience from the clinical trials from other institutions show that there is some amount of a viral reactivation. The problem why we didn't have the baseline incidence of viral reactivation is it's not uniformly done across all the studies. So it makes us very not comfortable making a decision without the data. So I think right now, as we see in the cohort of patients that we treated, we didn't see any, makes it easier for us to make a decision moving down the line.
Yeah.
The hard thing though, we know in the auto setting, we don't monitor for CMV reactivation, but you get it. And it's not disease, we don't treat it unless somebody's actually symptomatic. So, I think we're learning a lot about, you monitor it, but are you going to treat it if you see the reactivation and everything?
So we actually have a paper coming out very shortly in Blood Cancer Journal where we looked at about 40 BCMA patients where we did CMV monitoring, and the reactivation rate was about 20%, and included were two, one was pneumonitis and one was esophagitis. So I think it's real. You may not be seeing it perhaps because you're giving the IVIG, right? So I think that's, which we also do, but this was before we learned about that. So I agree with all of your recommendations. I don't think, we haven't been doing EBV and adenovirus unless they're febrile or have a cytopenia or some AE. But the CMV, I think, because the reason to monitor it also is you may want to hold the drug till you get several time points, right? Because the CMV could be rising like this, or it may rise and then fall. But before you hit that next dose of the BCMA bispecific, it'd be nice to have that comfort of okay, this is just low-level viremia that's going to get controlled. Because if you're going to give the drugs, guess what? You're now adding to cytopenias and costs with the antivirals. So I think CMV viremia is an area that we need to understand better.
I think we probably all agree that IVIG prophylactically is actually very important for this therapeutic, which is great. And also I think one of the take-home points are, if somebody is demonstrating signs of infection, if they're having fever or symptoms, we have to look not just at bacterial and fungal possibilities, but the viral possibilities and the reactivations do occur. We have a couple patients at UCSF that had severe anemias, and so we checked parvovirus, and lo and behold, their parvovirus is really quite high, and they responded really well to high dose IVIG. But that is one of the things that happens with these bispecifics. You really have to be on top of infectious disease.
Two other quick points I would make about IVIG is, number one, that the IgG dropping is just a pharmacokinetic issue, right? Incidence of severe hypogamma is 100% on BCMA bispecifics, and it doesn't necessarily improve when you stop the drug. It paralyzes the immune system for quite a while. So vaccinating people prior to BCMA therapy, I think, is super important. And then giving the IVIG as soon as you can get it approved. And then the last thing is, I would say, we have a growing group of patients with CKD in whom IVIG created problems, either created worsening azotemia or albuminuria. So we've decided to give fluids for those patients, and then not use actual weight but ideal body weight, and try to not dose as frequently, maybe just tolerate a little bit lower peak. But I think we haven't been using IVIG in these kinds of patients as much as we are now, and so I think historically the low osmolarity was pretty safe, but things we've learned.
Very interesting.